Siamo a Budapest al congresso europeo di neurologia, l'EAN, dove abbiamo appena assistito a un evento interamente focalizzato sulla neuromielite ottica e sulle sue più recenti possibilità di cura. Ne parliamo con Bruce Cree, professore di neurologia all'Università di California a San Francisco, uno dei massimi esperti mondiali di questa patologia e primo autore dello studio registrativo su inebilizumab, una nuova terapia da poco disponibile anche nel nostro paese. Professor Cree, first of all, which are the main challenges in diagnose and treat NMOSD?
Yeah, great question. So one of the big diagnostic challenges in NMOSD is to distinguish neuromyelitis optica spectrum disorder from multiple sclerosis. And the reason for that is that clinically there is a lot of overlap between these two conditions. Both conditions can present with optic neuritis. Both conditions can present with myelitis, spinal cord inflammation. Both conditions can have characteristic lesions present on brain MRI and on the spinal cord MRI. So there can be a lot of very similar features between these two conditions. There are, fortunately, a diagnostic test available, which is the anti-aquaporin 4 antibody test, that when is used as a cell-based assay, can cleanly distinguish between NMO when it's positive and multiple sclerosis.
In our country, very recently, has been launched inebilizumab, a new drug. Which are the most important data to be registered?
Yes. So the N-Momentum clinical trial, its primary endpoint was looking at time from initiation of treatment to first attack. And there was a very significant reduction in risk of attack, especially in anti-aquaporin 4 antibody seropositive patients, a reduction of about 78%. In addition, this product had an impact on disability, on prevention of hospitalizations, and also an impact on imaging measures as well. And it was the only clinical trial to incorporate MRI to date in neuromyelitis optica.
And safety were also good?
Safety was also very good. The overall safety profile was very similar to that of placebo. This was a monotherapy study as opposed to an add-on therapy study. One of the interesting features of this was very low rates of infusion reactions, which were comparable between active treatment and placebo. So that's an interesting feature of this drug. We're used to these monoclonal antibodies as having much higher rates of infusion reactions, especially those that target and deplete B cells.
Although the availability of this drug and also of other new drugs, it's still very much used rituximab, an anti-CD20 compound. Which are the main differences between inebilizumab and rituximab?
Yeah, so rituximab is also a B-cell depleting monoclonal antibody. It is targeted against CD20. Inebilizumab targets a broader range of B cells, targets pre-B cells as well as plasmablasts and some plasma cells, so you get a larger range of B cells. In addition, the product has been glycoengineered, it's afucosylated, it has enhanced binding to the Fc gamma 3 receptor, and that combination of features of the drug suggests that it may be a little bit more effective than rituximab. Now, we don't have head-to-head clinical trial data. Rituximab itself isn't a proven therapy in NMO. So there are data gaps for sure. But when we look at the overall responses to treatment with inebilizumab based on its clinical trial and compare that to off-label case series data, it does seem there is a more profound therapeutic effect of inebilizumab. Now, granted, there are lots of caveats there with comparing observational data to clinical trial data, but nonetheless, one gets the impression that because perhaps it's targeting a broader group of cells, perhaps because of its enhanced binding to the Fc gamma 3 receptor, that maybe the efficacy is a little bit better. There's also data from the clinical trial that looked at patients who previously were treated with rituximab who came into the study, and there was a small group of patients who had disease activity on rituximab and came into the study, and they had no evidence of disease activity during the course of the clinical trial. Small numbers, but nonetheless supportive of this notion that perhaps this product may be a bit more effective.
Very interesting. Last question. Here in Budapest at the EAN Congress has been presented new MRI data regarding inebilizumab. Which are the most important results of this study?
Yes, so data which is being presented here is reviewing the MRI data from the clinical trial. As I mentioned, this was the only clinical trial where imaging was used systematically during the course of study. Imaging was used to confirm NMO attacks. And that's a very important feature, especially for attacks that perhaps were a little bit more minor attacks. You would want to also see a new lesion present in the area of involvement. For example, if you had a mild attack of optic neuritis, you'd want to see a new lesion in the optic nerve on the correct side, right? If you had an attack of presumed myelitis, you'd want to see a new lesion present in the spinal cord and so on. So it was used as a way to help adjudicate attacks. It's the only study that used predefined criteria for clinical attacks and is the only study to date that has looked at MRI systematically. There was also some interesting features to this as well, because one of the unexpected findings that came out was evidence of disease activity that could occur without clinical relapse. So we did see some evidence of GAD-enhancing events involving the spinal cord that had no clinical consequence, almost suggesting that the event of inflammation that was occurring was somehow disconnected from the event of neuronal injury. And I think that is very interesting to know that you can have subclinical disease activity in NMO. This is the first time this has really been properly studied and investigated, and I think it's going to be very useful for us to understand NMO pathogenesis further.
Very interesting. At the end, how you will summarize the benefit of this drug in this particularly and severe disease?
Yeah, so this is a highly effective medicine that is dosed by intravenous infusion twice a year, very well tolerated, with an excellent safety profile, and is the only drug which has proved benefit not only in terms of attack prevention, but prevention of disability worsening. It also prevents hospitalizations, and lastly has an impact on MRI activity as well. So overall, I think it's a highly effective and very welcome treatment that is important armamentarium in this new age of therapeutics for NMO.